Good evening. I'm psychiatrist Jay Fauver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 26th year, Matters of the Mind is a live call-in program where you have the chance to choose a topic for discussion. So if you have any questions about mental health issues, give me a call here in the Fort Wayne area by dialing 969-2720. Or if you're calling any place around the country, coast to coast, you may dial 866-969-2720. Now, on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And I'll start tonight's program with an email I received this week. It reads, Dear Dr. Fauver, I'm 70 years old and I've been taking medication for depression, anxiety, and ADHD for the past 15 years. Could there be side effects from taking modafinil, also known as Provigil, bupropion, also known as Wellbutrin, Subvonite, which is the trade name for lamotrigine, vilazodone, which is the chemical name for Viibryd, L-methylfolate, and gabapentin that could mimic symptoms of Parkinson's disease. Interestingly enough, when you put that combination of medications together, I'm not seeing anything there that would mimic the symptoms of Parkinson's disease. There's a slight chance vilazodone, which is known as Viibryd, possibly could, because if you increase serotonin excessively, sometimes indirectly you can dampen down the dopamine transmission. Parkinson's symptoms are symptoms such as a tremor, a shuffling gait, no swing to your arms as you're walking, difficulty with facial expression. Sometimes people get a runny nose with Parkinson's disease. And it's a condition that's a neurological condition where you're basically not getting enough dopamine outflow from this middle part of your brain called the substantia nigra. It's right here in the middle part of the brain, and nigra striatum is another term for the nigra striatum is a part of the brain that shrinks down to maybe 30 or 40% of its usual size when somebody has Parkinson's disease and you're not getting enough dopamine. Adequate amounts of dopamine in the motor cortex where you move is necessary to be able to have these smooth movements. So if you increase serotonin excessively, sometimes you can get an offsetting where you decrease dopamine. However, you mentioned you're on bupropion, a good medication for ADHD and depression. It's increasing dopamine. You're also on modafinil. Modafinil is an interesting medication known as Provigil. It's been around for a long time, and it's a medication that increases histamine in the front part of the brain, and that's what keeps you awake. So you might have heard of antihistamines blocking histamine, making you sleepy and tired. Well, Provigil or modafinil increases histamine and keeps you awake. It also will slightly increase dopamine as well. So you have a couple medications there, primarily bupropion and secondarily modafinil, that can actually increase dopamine and offset any side effects that you could get from vilazodone in terms of causing any Parkinson's symptoms. L-methylfolate is a nice medication because it will offset any inhibition of the Subvonite, causing a dampening down of the enzyme methylene tetrahydrofolate reductase, MTHFR. Lamotrigine or Subvonite will make that particular enzyme not work so well, and in doing so can kind of stall the conversion of folic acid to L-methylfolate. L-methylfolate is the active byproduct of folic acid. That's the byproduct that you need to be able to manufacture serotonin, norepinephrine, and dopamine. So L-methylfolate is kind of like jumping the turnstile at a football stadium, where the turnstile itself is MTHFR, the enzyme that helps break it down, and lamotrigine, or I'm sorry, folic acid is on the outside trying to get in. Lamotrigine will basically make that turnstile not work so well. So that's why it's helpful to have L-methylfolate as a vitamin supplement overall. Gabapentin, you mentioned that. That's often used for anxiety and difficulty with sleep. Really nice medication for sleep, especially as we all get older, because as we get older, gabapentin is a medication that will deepen sleep, give you a more efficient sleep. It'll give you a lengthening of your dreams, and will also give you a deeper so-called slow wave sleep that recharges the body. So by improving the dream sleep, by giving you more of a recharging sleep for your body, that actually can help with longevity and decrease the likelihood of getting dementia. A lot of dementia researchers right now are actually recommending gabapentin for people for sleep because it tends to normalize the sleep architecture, and doing so can actually give you an improved sleep overall. So with that combination, I wouldn't think that would elicit Parkinson's-like symptoms unless you're having a bit of a tremor. That's the only Parkinson's-like symptom I could imagine with all those medications between bupropion and sometimes vilazodone or Vibrant. You can sometimes get a little tremor from those. But Parkinson's symptoms overall is where you have a shuffling gait, very little arm movement, masked faces, which is where you don't have much facial expression. It's a whole different phenomenon. So talk it over with your clinician and see what kind of options might be available for you. But overall, it looks like you're on a really nice combination of medication that will do a lot of different things. We never like to see overlaps of mechanisms of action with medication, but what you described is a really nice combination medication where they're all doing different things. Thanks for your email. Let's go to our first caller. Hello, Carlos. Welcome to Matters of Mind. Carlos, you have a very important question. You want to know how to tell a difference between a heart attack and a panic attack. Well, number one, a panic attack can give you a racing heartbeat, sweatiness, chest pain, tightness, but you want to make sure you're not having a heart attack. So the first thing you want to determine, Carlos, is that you're not having a heart attack. A heart attack can be diagnosed primarily by cardiac enzymes, which get in the bloodstream, and electrocardiogram itself. But they use cardiac enzymes and electrocardiogram as a means of diagnosing a heart attack. A heart attack is basically where some of the heart is not getting adequate blood flow. That will give you chest pain. For some women, it comes across just as nausea occasionally, or a achiness. Sometimes we'll give you an achiness up the jaw, down the arm. But people can have sweatiness with both a heart attack and a panic attack. But a panic attack is basically a condition where you've excluded other conditions like a cardiac condition. If you're having difficulty with a panic attack, such as the sweatiness, the dizziness, the lightheadedness, feeling like you're going to die, nausea, diarrhea, abdominal aches and pains, sweatiness, chills or hot flashes, either one can come across. Tremor is a common symptom of a panic attack, as well as chest pain and fast heartbeat. Those are all symptoms of panic attack. You want to make sure, okay, you're not having a cardiac issue, but you also want to make sure you're not having a thyroid issue, a glucose issue. We want to make sure you don't have a condition, especially if you're female, although you're not, Carlos, but if you're female, you can have a condition called postural orthostatic tachycardia syndrome, known as POTS. And young women, especially in their 20s, sometimes their adolescent years, but also in their 20s, can have the POTS symptoms, and that's where your heart just starts racing really fast. You get lightheaded, and you get very weak. And with POTS, it's something that will often come across as what appears to be a panic attack, but it's POTS, which is typically thought to be an autoimmune condition, and it's treated very specifically with high salt diet and various medications to alleviate that. Much more common with women, but it's something that's very important for us to identify. So with any kind of panic attacks, Carlos, the first thing we want to identify is, okay, what other medical conditions might be bringing this on? And then, if it is a panic attack, we want to see what might have precipitated the panic attack. Because many people will have their first panic attack when they feel like they're backed up in a corner in life circumstances. There's no way out. They are in a situation where they're just stuck, and they'll have a panic attack as a means of an adrenaline surge, and that will give them a lot of those symptoms. Carlos, thanks for your call. Let's go to our next caller. Hello, Patrick. Welcome to Matters of the Mind. Well, Patrick, you want to know about the difference between obsessive-compulsive disorder and just being used to a rigorous routine. If you're used to a rigorous routine, let's take it one step further here, Patrick, and say, let's say you're kind of a perfectionist. That's really okay. They used to call them type A personalities, but people who are perfectionists just like to have things done a certain way and a certain routine. Other people might notice it, but overall, it's not functionally impairing if you're a perfectionist. What do I mean by that? It means that you're still able to get stuff done, you're getting work done, and you're not too much of an annoyance to the people around you. OCD, obsessive-compulsive disorder, entirely different phenomenon. OCD is where the front part of the brain gets kind of stuck, and it's kind of like the old record players that had the needles on them. It's like the needle getting stuck, and you have a thought that comes to your mind over and over again, and you can't get it off your mind. And you know the thought doesn't make any sense, and a thought might involve contamination or an immoral type of thought where you just get stuck and you can't get it off your mind. And sometimes you'll do things as a means of trying to get that thought off your mind by excessive checking of things, repeating things over and over again. You might count over and over again. You're trying to distract yourself from that particular thought. And what happens, that thought goes through a loop right up here in the front part of the brain, and you have a hard time getting it off your mind. That's an obsession. The thought is the obsession. A compulsion is the behavior. So an obsession is where you're thinking about something over and over and over again. You can't get it off your mind. And then the compulsion is where you're doing things as a means of trying to address, give you some relief from that obsession. Now, a lot of people have what's called obsessive compulsive personality disorder. OCPD, obsessive compulsive personality disorder, it sounds like OCD, but it's quite different. OCPD will be where somebody's a perfectionist and so rigid to a degree that they get on other people's nerves. And they have a hard time with their marriages, with social interactions, with OCPD. They've got to have things so perfect that they get extremely anxious, irritated, and annoyed if anybody kind of gets in their space. Well, that becomes a psychiatric problem for some people where we have to kind of address that. But obsessive compulsive disorder, it used to be thought as somewhat of an anxiety disorder. Now we look at it as more of a brain networking problem. Obsessive compulsive personality disorder is something where it's actually functionally impairing and causing you to have a difficult time with interpersonal relationships and actually getting things done. And then you've got perfectionism, where, as you had mentioned, you just like things done in a particularly routine way. That's not considered to be pathological. As a matter of fact, perfectionism can be somewhat adaptive in a lot of ways. When I was a pharmacist, we were always instructed to count the medications and then check the prescription 3 times before it left the pharmacy. Well, in a way, they were just getting us that routine where you checked the prescription before it left the pharmacy 3 times, and it gave you that methodical recheck, recheck, recheck type of pattern. And that's really okay to have that. Thanks for your call. Let's go to our next email. Our next email reads, Dear Dr. Farber, I've been taking medication for depression for about a year now, and I feel it's not working anymore. I tried to tell my doctor, and he said my only option was therapy. Is there a way to know that a prescription might not be the answer anymore? I wouldn't give up on the medication for a lot of people, depending on the severity of the depression overall, any more than a cardiologist would give up on giving you any medication for your heart if your heart wasn't working as well as it should be. So what I often recommend to people is let's take a really good look at your past medications after, and I emphasize after, verifying the diagnosis. Maybe you don't have depression. If you have major depression, okay, we're going to treat that with certain medications for depression. But if somebody has what looks like a depression, and it's more of bipolar disorder where they have highs, but you're only telling us about the lows. Maybe you have thyroid or glucose disturbances, as I mentioned before. Maybe you have sleep apnea. I've seen a lot of people over the course of my career who are tired, they can't think, they will just have difficulty with not having motivation and energy, and lo and behold, they have sleep apnea. Sleep apnea is where you don't get enough airflow to the lungs at night because you're snoring or you're pausing and you're breathing, and thereby you don't get enough oxygen to the brain. So sleep apnea can be a factor. So if somebody has depression that we consider to be treatment resistant from the traditional antidepressant medications, we have so many other options now. There's been over 20 medications approved by the Food and Drug Administration in the past 6 decades that primarily increase norepinephrine, serotonin, and dopamine. But just in the recent years, just in the past 5 years, we've had other medications that will affect glutamate. Now, glutamate is the chemical that predominantly runs the outside part of the brain, the gray matter of the brain. 85% of the transmission of the chemicals in the gray matter of the brain on the outside here is run by glutamate. It's an excitatory neurotransmitter, and you got serotonin, norepinephrine, and dopamine that are originating down here in the brainstem, and they basically are giving advice to how much glutamate should be produced up there. So now we're getting to talk more about glutamate. So we have ketamine has been used without FDA approval for the past 25 years. You might have heard about that. S-ketamine is a nasal spray called Spravato, been around for 5 years now. Auvelity is an oral medication that does affect glutamate. That's been available for about 1.5 years. So we have these other medications coming out that can treat depression differently than the other medications did from the past. So if somebody's not getting well from their depression, I would want to make sure they're on the right medication if need be. If they need to be on a medication, I want them on a medication that's going to at least work for them. Therapy can be fine, but therapy is something where it is necessary for your brain to work, for the therapy to work. And we found this way back in 1987 when Prozac came out, fluoxetine. Prozac became available in 1987, and for the first time, people were able and willing to take a medication for depression because the prior antidepressants before Prozac in 1987, the prior antidepressants would cause dry mouth, lightheadedness, weight gain, blurred vision. People didn't want to take the older medications. With Prozac, at least it was tolerable, but the only thing Prozac did was increase serotonin, which helped you feel somewhat better. But the fact of the matter was, if the people felt better on Prozac and they felt a little bit less anxious and they weren't as likely to have crying episodes, they did better in therapy. So whereas I was trained in the early 1980s to always do the therapy first, and only if the therapy didn't work, then you would go to using a medication. Nowadays, we want to optimize the medication treatment to make the brain functioning as well as possible, to help with attention span, concentration, motivation, get the brain functioning as well as possible, then go on and deal with the issues in therapy that you might need to deal with, such as interpersonal relationships, challenges you might have at the job, and so forth. So now we often will try to optimize the medication first and then go to therapy. So I look for other options that might be available for you, but first and foremost, always make sure that diagnosis is correct, because if there's other medical conditions going on, that will be a factor for treatment-refractory depression. Thanks for your email. Let's go to the next caller. Hello, Bev. Welcome to Matters of the Mind. Bev, you had mentioned that you would wondered if you believe that your spouse was not taking if you believe that your spouse was not taking the antipsychotics that are prescribed, are you able to put your spouse on a psychiatric hold in a facility? A psychiatric hold is where somebody is admitted to a hospital involuntarily. Now, you have to have a reason for that. They have to be having some difficulty with being a danger to themselves, danger to somebody else, or being gravely disabled. And then you go to the spouse's treating clinician, and through the treating clinician, the spouse's treating clinician would then initiate that involuntary hold if those criteria were met. Now, gravely disabled means that your spouse would be not eating, not taking care of him or herself, and basically not doing the kind of things that should be done on a day-to-day basis due to the mental illness itself. Gravely disabled is kind of a gray area, but it often is used as a rationale for hospitalizing somebody against their will if they're just not able to take care of themselves. But more commonly, people are on an involuntary hold if they're a danger to themselves or somebody else, and that would be the usual criteria for getting somebody into a hospital against their will. Merely having non-adherence to medication wouldn't be a reason to have somebody in the hospital against their will unless it's causing them significant difficulties with caring for themselves. Beth, thanks for your call. Let's go to our next caller. Hello, Dustin. Welcome to Matters of the Mind. Dustin, you had mentioned that your adolescent is leaving for college this fall. Any advice on how to find a new therapist or help with the transition in providers? Dustin, I'd recommend that you have your adolescent look into some possibility for counseling and medication treatment right there on the college campus. Many college campuses have their own psychiatrists or nurse practitioners, sometimes physician's assistants. They have prescribers on campus, and they frequently have therapists. A lot of therapists will work on college campuses. And the nice thing about the prescribers and the therapists right there on the college campus is they are readily available to the adolescent, and they have a lot of expertise in taking care of the issues that are so prevalent among that age group. So it's nice to get them set up with somebody right there on campus, and to have somebody locally where the college is located. Now, we are doing a lot of video health nowadays. So with video help, I see, for instance, a lot of adolescents and young adults who are attending college, I'll see them as a clinician by Video Health. So that way we don't lose track of them. Now with Video Health, you can occasionally see somebody out of state if you don't have a state license in that particular state on an emergency basis, but more often than not, we need to have the person to be seen in the same state where we are licensed. So the patient needs to be in the state where I have a license, for instance. So with Video Health, that's sometimes an option too, to maintain contact with the therapist or the prescriber if the therapist or prescriber has a license in the state where your adolescent is attending college. Dustin, thanks for your call. Let's go to our next email. Our next email reads, Dear Dr. Fauver, is it possible that depression can be caused by inflammation? Chicken or the egg there? Is inflammation causing depression? Is depression causing inflammation? But there is a correlation there one way or another. We've got these little cells in our brains called microglia. And they are the white blood cells of the brain, basically. And in essence, they release a lot of these inflammatory proteins. And when they release them in the brain, they will fry these little helper cells around the neurons called glial cells, also known as astrocytes. So glial cells, there's a type of them called astrocytes, basically nourish each individual neuron. You have about 10 astrocytes around each individual neuron. And these astrocytes are like a pit crew. If you look at a NASCAR race or an Indy 500 race, you'll see this pit crew around the car when they come in for a pit stop. I think there's like 6 of them, 6 pit crew members. And this pit crew works in a very coordinated way, and they'll change 4 tires and load up 18.5 gallons of gasoline within a matter of 6 or 7 seconds very, very efficiently. Well, that's what we have in our brains. We have glial cells, also known as astrocytes, that are nourishing each individual neuron. If you have inflammation, the inflammation being caused by the microglia, you can have sick astrocytes. And anymore, we're not talking about individual neurons dying. We're talking about the glial cells around the neurons dying off and being very sick themselves. So a lot of the new research in psychiatry has to do with how do we keep the astrocytes more healthy, and how do we keep the pit crew around the neurons working more efficiently? Because that seems to be a factor in seeing a lot of these psychiatric disturbances. So imagine if a pit crew around an automobile is not functioning very well. You got tires that aren't getting changed, and you get a bunch of gas that's getting, a bunch of fuel that's getting spilled alongside the car. If they're not working efficiently, you're not going to have a very good pit stop. And that's what's happening in our brain with our neurons. If those glial cells just aren't clicking on all cylinders and they're not working efficiently, you're going to have trouble with neurological problems. Now, each individual neuron has anywhere between 10,000 and 50,000 connections to other neurons. So as the neurons get sicker and they become inflamed, you get less branching on the individual neurons. Now, some areas of the brain, like the hippocampus here, the memory center of the brain, the library center of the brain, that area of the brain is always turning over, and it has 50,000 connections per neuron. So it has all these different connections there. And if it gets sick, it shrivels up very quickly. So that's why a lot of people, when they get depressed and they have inflammatory effects overall, they will have trouble with their memory and concentration. But the specific symptoms that you might have inflammation associated with depression will not only be sadness, but also difficulty enjoying things. We call it anhedonia. You feel really slowed down and you feel really tired. And many people will have a slow processing speed of their brain. So it's like their brain has a slow internet speed. So those are symptoms that appear to be very characteristic of inflammation associated with depression. Now, we're not yet giving people anti-inflammatory medications for depression or prophylactically or as a means of trying to head it off earlier, but many of our medications indirectly will have anti-inflammatory effects. And we're finding that we're talking about circuitry disruptions of the brain that might be partially related in some cases to inflammation. Thanks for your call. Let's go to our next caller. Hello, Brian. Welcome to Matters of the Mind. Brian, you want to know if counselors or psychiatrists are required to report stalking to the police if no physical harm has been done. Brian, it's kind of it's a case-by-case situation. If a psychiatrist knows that their individual patient is threatening to harm somebody else, if their individual patient has expressed to the clinician that they're going to be stalking somebody and threatening somebody. In that case, the psychiatrists, based on this law called the Tarasoff Law, they are obligated to report that to law enforcement and ideally to the person who's the target. But our main obligation is to report that to law enforcement. But if they hear about somebody else stalking, what we might advise that particular patient to do is, if they're being stalked, that they should contact the law enforcement as a means of getting a restraining order or whatever needs to be done. Brian, thanks for your call. Do we have another email? I don't know if we have another email or not. I don't think we do. Well, with that in mind, there is another email. Let's try to get this in about 30 seconds. I just started working with my family doctor and she prescribed Wellbutrin. What if I start feeling worse? I'm not seeing any difference yet. About 1 out of 4 people on Wellbutrin or bupropion can feel worse right up front. 3 out of 4 people don't. Usually that's a dose relationship issue. Usually it's a genetic issue. Some people just aren't fit more for Wellbutrin, and sometimes you just don't have the right diagnosis for Wellbutrin. So if you do feel worse early on, make sure to talk to your clinician. Thanks for your call. Unfortunately, I'm out of time for this evening. I'm psychiatrist Jay Faulver, and you've been watching Matters of the Mind on PBS Fort Wayne, now available on YouTube. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.